pandemics are not a new thing, and this was to try and give some idea about the setting and the context for pandemics. So this slide is designed to show pretty much all the pandemics that there have been for which there are historical records. And as you can see here, this big purple blob and the blobs are the size of the number of people who have died. The big purple blob is the plague, yellow smallpox, Spanish flu, the plague of Justinian. Now, no one's entirely certain what the bug was that caused Justinian's plague, but it was probably plague, pneumonic plague, HIV and AIDS, and that's just the data up to the end of 2021. So far exceeds anything we've experienced with COVID. The third plague from the 1800s. COVID, as of March 2022, had been estimated to be responsible for the deaths of about 6 million people worldwide. Contrast that with, as I say, 25 to 35 million deaths from HIV and AIDS. There's the Antonian plagues, 17th century Great Plagues, Asian flu, Russian flu, Hong Kong flu, cholera, wool smallpox, 18th century plagues, swine flu, which was something that I was working with in 2009, 10, 10, 11 in my clinical practice, yellow fever, Ebola, and that's the 2014 to 16 Ebola outbreak, MERS, another type of coronavirus, and SARS, the original SARS-1 coronavirus. And so you can see what we've experienced over the last 2 years is by far not the worst plague that humanity has experienced. But look what it's done. And it will not be the last. So we have to find ways through civil society, through our political societies, and through our faith and scientific communities to manage better, because it is only a matter of time, as I think this shows you, before another plague happens of some sort. This section is about grief, and for intensive care physicians, grief is a feature of our normal everyday working lives. In the UK setting, about 15 to 20% of people who are admitted to an intensive care unit do not survive. So we are very familiar with grief, grief in our families, sometimes grief that we experience for having lost a patient. It is something that is normal for us. People who have severe acute respiratory failure, which is the acute lung failure that you end up in intensive care from infections, 35 to 50% of those die, and that figure has been unchanged for 50 years. So again, we know and are familiar with severe levels of mortality from respiratory disease. The problem over the last 2.5 years in our setting has been everybody had severe acute respiratory failure. So actually every single patient we saw came into that setting where there was a significantly higher chance of them dying than our general population. But worse than that, actually, it wasn't so much the dying that was the thing that impacted on us as healthcare workers and even on wider society and the families. It was the way in which they died. And one of the things about the pandemic and the public health measures that have been required is that people were in hospitals separated from their loved ones, which meant that actually as a healthcare worker, and I can talk about it only through my lens, I am used to having the families at the bedside. If I need to talk to you to tell you that it's not going well, or that something I think you need to hear, or that your relative is dying, I'm used to being able to look you in the eye and tell you that in person. This slide represents one of my colleagues who in the beginning we had no way of communicating in a visual way, but we were very fortunate that we had a donation of iPads. So we had an iPad tablet for every single bed in our intensive care unit so that we could at least visually see our families and the families could see their loved ones. And it seems like a great idea, but technology, it will solve everything. Technology does not solve everything. And actually, it is not an easy thing to have to carry to tell someone's loved ones or their children that they are dying, and that whole experience to happen via Zoom. There are a large number of families and loved ones and healthcare workers who will be forever scarred by those experiences. I was talking to one of our former intensive care nurses, and I said former last week, and the reason she doesn't want to do intensive care anymore and has gone to work in another bed of the hospital is because she cannot have another conversation with a family via Zoom to break or to be involved in the bad news. The trauma that she has experienced from that is so great. And that has been replicated across the world. So many people have been separated from their usual support systems and the usual way in which they would handle that grief. They've not seen what the dying process looks like, which means it's so much harder to accept. They have not necessarily been involved in it or had the chance to take it in or discuss it or have any of the answers because it's just been remote. And I think that has fed some of the misinformation that has been circulating, particularly on the internet. People saying, well, I've never seen this. Well, you haven't seen it because it's been kept shut away, because that's been part of the necessity of public health. But it has been incredibly difficult. I have come across Elif Shafak during the pandemic. Now, she is an amazing writer who's of Turkish origin, who writes both in Turkish and in English, who I first met because I took part in a Radio 4 Today programme between Christmas and New Year. The Radio 4 morning programmes have a series of guest editors. And one of them was Professor Sir Jeremy Farrar, the head of the Wellcome Trust, who is an expert in pandemic preparedness and pandemic responses. And Jeremy curated a programme around uncertainty. And Elif wrote the most amazing essay about uncertainty that resonated with me in the context of uncertainty and March 2020, when there was a virus we'd never met before. We didn't know what it was going to do to people, what it was going to mean to us, our families, and a whole host of other things. She just nailed the uncertainty of everything and everybody from that time in March. But then later on she wrote this, and it's in the New Statesman, and it's really available for those that want to be able to find it. But she was writing about grief and how the closedness and the removal from our normal structures and our normal processes of processing grief is going to be an issue for society, that we have not been able to process dying, of which has been happening in large numbers, in the way that we would normally. The rituals with which we would normally pass those things have not been happening. Here in the UK, funerals were not happening in the way in which they have done previously. Families were not able to gather by the graveside. They were not able to spend time together and talk about it. The grieving process was put on pause or not allowed to happen at all. And Elif has rightly argued that actually so much suffering and hurt, grief has been less visible, but it's still there. And that unless we acknowledge the grief still being there, and we find ways as a society of allowing it to happen or marking what has happened to us as being an event, we will not be able to move on. And I think she's right. And I think it matters as much for me as a healthcare worker who has stood at lots of other people's moments of grief. And it's one way in which actually the clergy and doctors are probably closer than most people think. We have a tremendous privilege in our work that we stand with people at the very best and the very worst moments of their life. And we are experts in some small way at grief, different aspects of it, but nonetheless. But there has been an absence of grief, and that cannot continue. And for healthcare workers, I think this comment, and it's from a surgeon from the 18th century, is never more true. Every surgeon carries within himself a small cemetery where from time to time he goes to pray. Now, every healthcare worker can tell you the list of people or the situations that did not go as they hoped they might, or the ones that were just closer to home that resonated in some way, and we carry them with us. It's always been like that. The problem with the last 2.5 years is there has been so much more. Healthcare systems across the world were overwhelmed. There is no other way to describe it. Even the most resource intensive healthcare systems, if you think about somewhere like New York City, they had moments where their healthcare system demand exceeded the capacity for it to be supplied. And so actually things that people would normally have wanted to do were not possible. And so there are far more people in the graveyards in our head, and that has consequences. Resilience. I find resilience a slightly difficult concept, in that the term in which people use resilience is often that people need to be more resilient. Individuals need to be more resilient. And what we effectively are saying when we say, I think you need to be a bit more resilient, is basically that I think you just need to man up a little bit more. That is not how resilience works. No one got more resilient by being told they needed to be more resilient. It is a form of victim blaming, usually, because people are not resilient because the systems in which they're functioning are not resilient. Their communities are not resilient. And so I find it a slightly difficult and loaded concept, but I'm going to try. The entrance to Addenbrooke's has this just inside the main reception. And it's kind of the equivalent of telling people to be more resilient, isn't it? It will pass, whatever it is. It's like, well, actually, it might. And there have been many days where I have left the building and I have looked at the sign and I thought, you know what, it's been a really bad day, but it will pass. The sun will come up tomorrow and I will come and do my job and it will be okay. But it's not necessarily the most helpful of concepts. And just to give you some idea of what we have been through, this is the timeline of the number of people in hospital in the United Kingdom from the 1st of April 2020 until 2 weeks ago. Actually, today, the figures came out at 4 o'clock today. They do every week now. And there's 17,000 people currently in hospital. So actually, the end line here should be slightly greater than it is. But you can see 17,000 people in hospital is only 3,000 short of what we had in wave 1 of 2020, when we were also very worried. It's a lot more strain on the system than perhaps we're seeing in the headlines at the moment. But these are the number of people in intensive care units. And you will see we had 2 enormous waves in the UK, but thanks to vaccines and improvements in treatment, actually, we've got ongoing low levels of admission to intensive care, but we have not, touch wood, thank the people who were amazing enough to come up with vaccines, whatever way in which you wish to attribute that. We have not seen that, and I hope we never do again. But we're going to come back to vaccines. For intensive care, what wave 1 and wave 2 meant, just to give you some idea of the scale of the strain on the system, is that actually we needed an extra 2,251 intensive care beds in the UK. So the equivalent of us building another 141 intensive care units. Now, you can't train enough nurses in that period of time to open another 141 intensive care units, or the doctors. It takes years to train the staff. So what we did is we stretched what we had, as healthcare systems across the globe have done. You take what you have and you do the best you can with it. But it comes at a cost, an enormous cost. And the cost is on the people for whom you are stretching it. Normally, we would say that in the UK setting, an intensive care consultant can be responsible when they're on duty for about 12 patients at a time. That is what's considered and evidence-based wise shown to be safe and deliver good quality care. During the pandemic, so in January 9, 2021, intensive care consultants in the UK were responsible for between 16 and 33 patients. So we have stretched beyond what we know provides good quality care and was safe, because there was no other option. We supplemented it with non-specialist staff, but we cannot, without being dishonest, say that we provided the standard of care that we would have expected to give you any other day of the year outside the pandemic. And that creates moral injury. People carry that with them. And it's led to this consequence. And these are two papers that have been looking at the well-being of healthcare workers that have been working, in one case in intensive care and the others in hospital during the first two waves in the UK of the pandemic. So the one about intensive care was done during June and July 2020, so after wave one, and it showed that 45% of intensive care staff had met the threshold for probably having clinically significant mental health issues related to their experience. So 45% of the nurses and the doctors and the physios in your intensive care unit after wave one had symptoms compatible with post-traumatic stress, with depression, with dependency on substances to be able to get up and do their job. 45%. 6% of them actually met the criteria for severe depression, and about 40% of them had symptoms that were compatible with post-traumatic stress. Wave one, as you will see, was significantly less bad than wave two. And so the data here was around July 2020. A lot has happened to those people who were already not in a good place since 2020, and that data has not been repeated, but I can guarantee you that the well-being of the staff is no better, and probably in many cases a significant amount worse. And to highlight some of that, today in the British Medical Journal has come an harrowing but important personal column by a man called David Oliver. David Oliver was elected the president of the Royal College of Physicians in March of this year. He is an outstanding geriatrician and elderly care physician who has been on the front line of the pandemic, looking after that community in his hospital over the last 2 years, who unfortunately caught COVID himself round about Easter, when so many people in the UK has. David has had to withdraw from being the president of the Royal College of Physicians because his mental and physical health, as a result of the toll of COVID, means that he cannot take up the post later this year. And he has chosen incredibly bravely to share that with the public. And I commend it to you to read, because it explains better probably than I'm ever capable of the consequence of the pandemic for healthcare workers. The other study that's here, again, looks at 2 waves across frontline doctors in hospital, and again, talks about people saying, I am COVID cannon fodder. I have been exposed. I have not had the PPE. I have been unprotected. I felt alone. I felt isolated. I felt scared. And I think that's the thing, the uncertainty of a virus no one has ever met before, that does things that we knew not what in March 2020 to people's health and well-being. You don't know whether you're going to bring it home to your family. There were junior doctors whose landlords refused to have them resident in their rented accommodation because there were doctors and they were thought to be an infection rate themselves. Now, if you live in parts of sub-Saharan Africa, that is not a new phenomenon. People have been ostracized for being healthcare workers all over the world for many years. In the UK, that was a new thing. People had not experienced that level of inequality that is experienced by people elsewhere before. But it just shows that we are never far away from being more connected than we think. And the healthcare workers, just to give you some context, because women both in the UK, in the NHS, in academia, and across the world have been disproportionately impacted by the pandemic. And I thought I'd give you a few examples of that. So NHS staff are 47% women, which sounds like it's probably quite equal, doesn't it? That actually, well, half of NHS staff are women. However, the women are more likely to be in the lower paid, more likely to be exposed, more likely to be unwell and not protected from COVID roles. And that's the same in the NHS as it is all over the world. And all of the data shows that the women actually have had a higher chance of getting long COVID or long-term sequelae from COVID, They've also had more burden of trying to deliver caring alongside doing their work, and a whole host of other experiences. And they've been the same for the NHS as well as the rest of society. Only 6% of female staff in the NHS are doctors. The majority of them will be administrators, healthcare support workers, and predominantly nurses. The WHO have done a tremendous report around gender equality in the wake of the pandemic, that again I would recommend, if it's an area of interest to you, to read. And they have showed that actually the pandemic intensified women's unpaid care and domestic workloads. Women are more likely to have to do unrecognised, unpaid caring in all circumstances, but actually during the pandemic that got worse, significantly worse. Female essential workers had increased risks of catching COVID at all. Why? Because they're more likely to be employed in care type roles where they're going to be exposed. 3 times higher infection rates in healthcare workers who are women compared to their male counterparts. And in Italy, 72% of long-term care workers were not born in Italy. So we were infecting people from all over the world to try and provide healthcare settings in high-income countries. Now, we can have another discussion, I suspect, about the appropriateness of importing people from low-income settings to come and provide care in high-income settings. And I suspect we'd probably agree in many respects. But not only did we import them, we also didn't treat them very well and provide them with the PPE and the protection from infection that they needed. And in academia, things have also been troublesome for those of us that are researchers. And this is from the National Academy of Sciences in the United States. They have done a report that has very clearly shown that the careers of women in science, engineering, and medicine were selectively disadvantaged during the pandemic. And the key things they identified were women's representation in STEM was improving, that there's a confluence of social stresses, so our care burdens alongside trying to maintain our work burdens, intersectionality, academic productivity. It's very hard to be academically productive when you're trying to homeschool, your primary school age or younger children. That isn't something that's uniformly experienced. Women are more likely to be carrying that burden. Institutional responses were not always sympathetic, and I think that's the same in academia as it is in many other settings, to those added burdens. Work-life balance and the gendered division of labour. In many households, I am delighted to report, not in mine, the division of household labour that needs to be done is not equitable. We know, and there's good data suggests that actually women carry more of the burden, even if they're working full-time, than in many of their male counterparts. Collaborations which foster people's careers were fractured by the pandemic, by the social restrictions. So actually being advocated for and supported to develop, and there are fewer women who are lower down in academic ranks than higher up, so they lost those advancement opportunities. Networking and professional societies, such as this, they have not been possible for some time. Academic leadership and decision-making, people reverted to talking to their friends and not necessarily being as diverse and inclusive as they could be. And mental health and well-being, I've already talked about. There was also this about resilience. Michael Marmot is someone who has specialised in the UK of working and looking at the health inequalities in the UK health system. And we have had a problem for a long time. This isn't a new thing, but he wrote a really fantastic report looking about building back fairer, the COVID report. And he looked at the UK system and the impact of COVID. And it was very clear that the existing health inequalities were driven even further apart during the pandemic. And I don't think that's just something that happened here. I think that has happened across the world. But if you haven't read it, I do suggest that you might want to. They talked about the burdens of previous health conditions. People were more likely to do badly in the COVID pandemic if they already had health conditions. They couldn't get access to healthcare that they might normally have got. They were scared of going out. They were isolated. And COVID was so much worse if they did get it. the deprivation of your area of residence, where in the UK you lived, mattered to how well you were treated. The difference between Birmingham, and I went to visit a hospital in Birmingham in January 2021, and their experiences of the pandemic were very, very different to the experiences in Cambridge, nice middle class affluent Cambridge, and some of the slightly less affluent parts of Birmingham, which is where I was visiting, were not the same. And I have a PhD student who's based in Uganda, and his experience, again, completely different. Context matters. Living conditions, no surprise to anyone who ever works with respiratory infectious disease, be it tuberculosis, be it bacterial pneumococcal pneumonia, be it respiratory viruses, crowded housing and ventilation, and huge amounts of things around living conditions really matter. Employment, ethnicity, and religious affiliations also mattered in the UK setting. And one of the reasons it's suspected that actually outbreaks centred in places like Birmingham is that some of the faith groups and the faith communities and the way in which their faith is practiced led to widespread spreading of coronavirus infection. As people of faith, you want to gather together and have fellowship. There is nothing probably more deadly in a respiratory viral infection that's so easily transmitted by droplets and the air, to have a large number of people in a space that doesn't have good ventilation in close proximity. And religious fellowship has led to the spread of this infection as it's led to others. And I think the experiences of that in the UK are paralleled elsewhere. And one of the reasons that I think this is that I had a conversation, a public conversation for the Wellcome Trust with Rashida Farrand, who, although she's affiliated with the London School of Tropical Hygiene, actually lives and works in Zimbabwe and has headed up the COVID response in Zimbabwe. And so much of what we talked about was common to both our settings: the uncertainty, the fear, the lack of resilience in the healthcare settings. Our hopes and fears about what came next was common across everything that we've shared. And I was reflecting on it earlier today. It's nearly a year since I had this conversation with Rashida. And the reason that we had it, it was the run up to the G7 Accord about what we're going to do about pandemic preparedness. And Wellcome suggested it's probably a good time to have someone from the COVID response in Zimbabwe and someone from the UK talking about their shared experiences and what they thought needed to come next. And so much of what we said we hoped for has yet to pass. And by that, I mean, this is the 7-day rolling average of the number of people who have COVID infections as of the 19th of July across the world. Now, the case finding varies across the world, but you will see it is not equitable. And interestingly, the African subcontinent particularly, the data is probably less reliable than we would hope. But South America, large parcels of the data is probably more robust. But it's not great, is it? We have managed to have every part of our world touched by this virus, and we still haven't got ourselves organised. Hope. This is the thing that I found much harder to talk about in the current context. Bits have given me hope, but maybe not the things that you would want me to talk about, but I've tried. So in March 2020, and for those few months, there was much support and we felt lifted up as healthcare workers. There was clapping on Thursdays, everybody was rooting for the National Health Service. People really felt like they were in it with us. And this is a photograph taken by one of my former PhD students from the intensive care unit at St Thomas's Hospital, looking out across Westminster Bridge. And it's for one of those Thursday nights clapping for carers that happened in the UK. And you'll see the blue lights. They were the police officers and the other emergency response workers that all congregated on the bridge. They turned on their lights. The river police produced their fountains from the boats. Everybody was trying to show them that they cared about what was happening. Unfortunately, nobody's clapping anymore. And that is really felt here and around the world. And when I say no one is clapping anymore, I mean that people who are healthcare workers and people like me are probably more abused for the work we do and sharing the work we do in public than we have been at any other time of my career. Yeah, and again, a conversation perhaps for another day. But I and many people like me, and I suspect many people like you, have experienced people's lack of tolerance that has got worse over the last 2 years. And I understand, because we're all carrying trauma, but no one is clapping now. Hope. This gave me hope. I was incredibly fortunate, as were many in the UK. I got an email in January 2021 to tell me that my vaccine appointment was ready. I mean, that was an amazing day. It seems so routine now, doesn't it? Well, we have a vaccine for COVID. If you had asked me in March 2020, did I think that we could get a vaccine for coronavirus, I would have told you it was extremely unlikely. We had never, ever generated any form of successful vaccine for a coronavirus. They're notoriously difficult. The fact that actually we did it in under a year is an amazing thing. One might even call it a miracle. But we have done it, and the vaccines are there. And this was a brilliant day. I had hope this day. And actually, research has provided me hope. When you look back at what has been achieved, it has been amazing. For a virus we didn't know about, that we had never seen, and that we knew very little about. Actually, by 100 days in, we had discovered, thanks to research, that dexamethasone saved lives. The clinical trial for that started on the 9th of March, and by the 16th of June, the entire world knew that a cheap, widely available across the world therapy improved mortality from hospitalized patients with COVID. I mean, what we can achieve when we try is amazing, and subsequently a whole host of other knowledge has been gained. But it's been gained because communities came together. People who were unwell volunteered to take part in research. Everybody did their bit, and so I have hope that there were community sense that we all needed to do something together, and it has achieved amazing things. And the finding of dexamethasone has been demonstrated to have saved 1 million lives across the globe since the 16th of June 2020. Okay, that is no small thing. And the UK research setting that has actually shared knowledge across the world has been a source of tremendous hope for me. Perhaps I'm biased because I'm a researcher, but actually we have found the genetic causes of why some people end up in intensive care with COVID. We found 26 different types of gene locus that increase your predisposition to getting critically ill and needing to meet someone like me if you get COVID. We have found huge with the COG UK, so the genomic sequencing. At one point, COG had sequenced half the viral genomes for COVID in the world, and have shared their technology and learning freely across the world to facilitate others being able to do the same. And now, as they shouldn't be, they're not the biggest sequencers in the world because others have overtaken them, because that's what should happen. ISARIC has been a pandemic preparedness clinical platform that's been available for more than a decade, that was activated very early on to look at COVID so we can understand the clinical characterization, and that's based in the UK and beyond, and has been tremendous. And the recovery trial, which is the one that found out about dexamethasone, has randomized more than now 47,000 participants in the UK and is open in countries across the world. So actually, research has provided hope that we have a way out of the pandemic. And vaccines. I said we'd come back to vaccines. We have vaccines, we have treatments, but the problem is not everybody has access to vaccines and treatments and oxygen and things that we know saves lives from COVID and from a whole host of other things. And the conversation that Rashida and I had was hopeful a year ago that perhaps the moment had arrived where people would commit to make sure that there was equity in sharing the tools that we have to fight COVID. that everybody who needed them could have a test or a vaccine or therapy. Unfortunately, so little has changed on that front over the last year. And this is as of the end of last week, the vaccines per, I think, 100,000 of population. I've got a bit of the covering my legend at the top of the Zoom, so I can't see. And you can see it's not equitable. Vaccines are not available to everybody. And that is a problem on a scientific grounds, because actually pockets where the virus is allowed to flourish will result in more mutations. It's simple maths. The more transmission events there are, the more chance that one of them generates a mutation, and the more chance that that mutation will generate one that has got a survival benefit for the virus compared to the others. We saw it with Delta, which swept the world. We've seen it with Omicron, which is currently sweeping the world because it overtook Delta. Until we can make sure that vaccines and treatments and testing are available to everyone, no one will be safe. And I talk about equity rather than equality. And this is just to illustrate where I think we need to move from one of the clinical psychologists that I follow on Twitter. We talk about the reality, and people talk about equality. It's like, yeah, give everybody the same box to stand on, because that would be equal, wouldn't it? Everybody's having the same help. That is not what we need. Everybody's needs and every healthcare setting's needs and every society's needs are different. If we're talking about equity, we need to give people what they need so they can see over the fence. If we're talking about justice, we need to take the fence away completely, because it shouldn't be there. These are structural, systemic barriers to everybody thriving. But actually, I would say that we should be aiming for more than justice. We should be aiming for inclusion. Not only should there not be a fence, but everybody should get to play in the game too. And so that's what we haven't managed. We are still very much at the reality end of this spectrum. And the hope that I have, and I suspect the hope that is shared widely in this room, is that we're at the other end and we reach inclusion. And to finish, I think this is probably where I'm at, and it probably dates me in terms of my music taste. But I think it's from a song called God Part 2 by U2, from their Rattle and Hum album, that don't believe them when they tell me that there ain't no cure. There's absolutely the case. There is a cure for the thing that ails us in society. There absolutely is. And us deciding to not do anything about it is a choice. It is not insurmountable. But we are still in a situation where the rich stay healthy and the sick are staying poor. But if I believe in anything, I believe in love, and we should be able to deal with it.